behaviors. So things like smoking is certainly a driver of increased cardiovascular disease, and physical activity and poor dietary patterns. And also there are healthcare system factors that can contribute. So things like maybe stigma and discrimination from the healthcare system that drives people away or prevents them from accessing or using services.
You can kind of draw a line through Eastern and Western Sydney. Western Sydney is where the lower SES suburbs generally are, and people who are poorer tend to live. And I grew up in Western Sydney. And on that side of the Red Rooster line, you've got a lot more McDonald's, KFCs, Burger Kings, things like that. So I think that really speaks to what you're saying in terms of access to fresh food versus access to the ultra-processed, quick, accessible, unhealthy food, which may contribute to poor health, particularly if you've got people with serious mental illness living in those poorer areas like you're alluding to.
The day one implementation problem might be like, okay, so now can we get it implemented in the real world with routine care, with everyday, providers? But then to me, the more interesting question is like the day 500 question, is it still there? After we've put resources into sustaining it, like what happens over time?
Before we dive into today's episode of the Mental Wellbeing College, an important disclaimer. We do dive into the weeds of mental health, which means that at times we discuss sensitive topics like suicide, self-harm, and substance abuse. If hearing such discussion does bring up distress for you, please do seek the psychological and professional treatment that you need. The content covered in this episode is not intended as a substitute for professional mental health treatment.
Dr. Kelly Aschbrenner, welcome to the Mental Wellbeing College.
Yeah, thank you for having me.
And it's fantastic to have you on all the way from New Hampshire in the States or thereabouts. I really appreciate you joining me for what is going to be a really important discussion on the physical health disparities of people with serious or severe mental illness. This is, I think, a topic that many people won't have much knowledge on in terms of what are the physical health disparities. I myself, going through my own psychology training, Kelly, had no idea that people with serious mental illness had such disparities. So can you tell us a little bit about what the physical health plight is of people with severe or serious mental illness?
Sure. So we know that people with serious mental illnesses like schizophrenia, bipolar disorder, major chronic depression, that people in that group experience, depending on estimates you're looking at, a 10 to 30 year reduced life expectancy. And that is not due to elevated rates of suicide. It's due to both communicable and non-communicable diseases and primarily physical health problems. And the number one physical health problem is cardiovascular disease.
Right.
That's causing this early mortality.
Mm-hmm. So people with serious mental illness are dying earlier than the general population, and not necessarily because of, like you said, rates of suicide, but because of these preventable diseases. What are some of the other, in particular, health disparities or causes of this mortality gap? So you said cardiovascular disease. Are there other key drivers of that for people with severe mental illness?
Well, if we're talking about cardiovascular disease, that's primarily there are a number of factors that can contribute to increased cardiovascular disease in people with serious mental illness, and that includes things like biological factors. So there's evidence that people with serious mental illness may have they may have a biological age that doesn't match their chronological age. So they may be older biologically and functionally than they are with their chronological age. And then other factors include health behaviors. So things like smoking is certainly a driver of increased cardiovascular disease, and physical activity and poor dietary patterns. And also there are healthcare system factors that can contribute. So things like maybe stigma and discrimination from the healthcare system that drives people away or prevents them from accessing or using services, healthcare services, other things like not being able to afford to go to the doctor and to get healthcare, and maybe even not knowing, even if you can afford and you feel like going, you're not able to go because you really aren't sure how to access healthcare. So I think it's a real, from what we understand, a combination of those biological, behavioral, and then healthcare system factors that are contributing to certainly increased rates of cardiovascular disease. People with serious mental illness.
Yeah, it's pretty stark. I mean, if we stick just with the lifestyle factors for a moment, having a look at some of the data that I've seen, that people with serious mental illness account for more than 50% of the cigarettes smoked here in Australia, for example, despite the fact that they don't make up 50% of the population. And like you said, rates of exercise and physical inactivity are much, much lower, and it paints a pretty stark picture of physical health when you add these things together. The poor nutrition, like you said, as well. I think much higher quality or much lower quality foods and higher intake of ultra processed foods and pro-inflammatory foods, and you add these things together and can see how it may contribute to something like cardiovascular disease, increased rates of diabetes. So a pretty stark picture.
Yeah, and I'm glad you brought up, actually, some of what you mentioned were social determinants of health. So structural things that can also contribute, and maybe even disproportionately contribute in people who are living with severe mental illness, contribute to things like what people are eating and their level of physical activity. So the structural things like food security or food insecurity and the places where people are living. So the quality of their housing, availability of transportation, even maybe not living in neighborhoods where they feel comfortable going for a walk or being physically active. So those, we also are very interested in thinking about the structural things around people that may be also contributing to health behaviors.
Yeah. So is it true then that people with serious mental illness live in lower socioeconomic areas, and serious mental illness tends to propagate in things like poverty and low SES areas?
Well, we know there's a relationship between social determinants of health and mental illness. And so you can then think about why that might be and why people with mental illness may be exposed to more negative or adverse social determinants of health. And so if you're living in if you're living under those conditions, and if you're dealing with adverse determinants of health, then it would affect your ability, your own health behavior, certainly.
Yeah. We have something here in Australia called the Red Rooster line, which is Red Rooster. I don't even know if you have that in the States, but it's a takeaway restaurant like Burger King or McDonald's. And the idea is that you can kind of draw a line through Eastern and Western Sydney. Western Sydney is where the lower SES suburbs generally are, and people who are poorer tend to live. And I grew up in Western Sydney. And on that side of the Red Rooster line, you've got a lot more McDonald's, KFCs, Burger Kings, things like that. So I think that really speaks to what you're saying in terms of access to fresh food versus access to the ultra-processed, quick, accessible, unhealthy food, which may contribute to poor health, particularly if you've got people with serious mental illness living in those poorer areas like you're alluding to.
Oh, yeah, of course. And we've heard from participants in our studies who talk about even if they have access to, let's say, fresh fruits and vegetables and lean proteins, things they could buy at the grocery store, it maybe they don't have the cooking supplies. Maybe they don't have a kitchen at home with proper cookware or a way to store fresh fruits and vegetables. I mean, so many things that the way that people are living, their housing conditions can also impact, even if they have access to fruits and vegetables and to other healthy foods, that may make it hard. And it may be also, we've heard, it can be, cooking for one person is not as enjoyable at times. We're cooking for more than one person. So also the social isolation if you're living alone. It can imagine, we all know that it can be challenging to cook a healthy meal for one person. So that may be also a part of if we're talking about eating and what people experience, a part of the experience that could lead to eating more of the processed foods or fast foods.
Yeah. So is it so that people with serious mental illness are more likely to live alone, Kelly, or is that part of their experience?
Well, we know that social isolation impacts people who are living with serious mental illness. And so it's really important for us to think about what that means and who might be in their lifestyle and are they living alone and, all of that, those things to affect your social network and your social connections and your social support can affect your health behaviors and your overall physical and mental health.
Yeah, I think it's a really nice point. And there's a story that comes to mind with a friend of mine who was going through schizophrenia at the time, which I think illustrates the point you're making as well. And he was in the recovery phase, wasn't going through any psychotic symptoms as such, but had been on a lot of antipsychotic medication, which had been really helpful for his schizophrenia, but it caused a lot of weight gain, particularly around like the central kind of abdominal area, kind of that beer belly phenomenon. And he was really self-conscious about it. And the way that contributed to his lifestyle behaviors was, as a 20-something-year-old male at the time, being really self-conscious about that as a result of, the side effects of his medication, didn't really want to exercise as such. And, we would go for a walk in the park, but he didn't want to go to a gym. And the walks would be at a time of day when there weren't too many people around because of the self-consciousness. So I think a really nice point you were illustrating there, right, about like how the symptoms of mental illness and experience of someone with a mental illness can play into their physical health. It can be kind of that interaction as well. So you mentioned something as well, Kelly, about the healthcare factors, stigma, discrimination. Can we touch on that a little bit? What does that look like for someone with serious mental illness in terms of stigma and discrimination from the healthcare system?
Sure. And the stigma could be perceived and it could be actual stigma, but the way that someone experiences it is maybe feeling like, or having the actual experience of not being heard by a provider or not taking your physical health concerns maybe as seriously especially if your mental health concerns seem more prominent or they're displaying as more prominent. So it could be that people experience some discrimination, certainly in being seen by providers or having their our stigma and discrimination because of the mental illness.
So is it that they're not taken seriously if they have a complaint about their physical health, and it's the focus of the consultation is really on everything about their mental illness as such, and that dominates the consultation? Is that what it might look like?
That could happen, and it could not be the fault of a provider either. It may be that a provider is focusing on the thing that's in front of him, and that's somebody suffering from some psychiatric symptoms, and that is what they're needing to address at that moment. But maybe the person experiences is the physical health symptoms not being seen. It could also be a part of just having fragmented healthcare system too, in which people aren't always able or trained to provide care for both your physical and your mental health at the same appointment or at the same time. So that certainly, you can imagine that could play a role in someone being able to have their symptoms addressed.
Yeah. The silos of healthcare, that I'm the psychologist who deals with everything from the neck above, and the exercise physiologist deals with the neck below, etc. Those kinds of silos I think that you're alluding to. So stigma, discrimination, what's the consequence of that for someone with serious mental illness? If I am perceiving that level of stigma from a healthcare practitioner, what's the outcome there?
Well, it may be that you're just less likely in the future to bring up some of your we're talking about physical health concerns, your physical health concerns, maybe you are worried that they won't be taken seriously, or maybe you're worried that someone would, minimize them. So I would imagine that you may be less likely than in the future to seek care, or you may wait until a problem becomes really serious in order to have your physical health addressed.
Yeah, I can imagine it can limit the opportunity for preventative care or early intervention in that case. So, yeah, really important.
Yeah.
Hello, everyone. A quick break from today's episode. At the Mental Wellbeing College, we are committed to the goal of communicating evidence-based wellbeing strategies out to the broader community. The goal of this podcast is to bridge a gap between self-help material and peer-reviewed research by providing evidence-based discussion that respects the nuances of psychology, but is digestible for all audiences. Ultimately, I hope that you as a listener feel empowered after each episode so that you can take away and implement strategies to improve your own mental well-being. If you have gained value from this episode of the Mental Wellbeing College, I would be so grateful if you were to hit subscribe or follow, or to share this episode with someone that you love. This is how we continue to grow the show, get the message out, and to impact people in need by providing such information and strategies. Thanks so much for tuning in. It means a lot to us here at the Mental Wellbeing College. And now back to today's episode.
So that brings us then, Kelly, to some of the focus of your work, which is the interventions. What can we actually do? How can we set up interventions to help with the dilemmas, the plight that we've discussed of the physical health of people with serious mental illness? So just broadly speaking, what are some of the interventions? What are some of the ways to go about helping with this dilemma, this plight, this scandal that we've talked about, Kelly?
Sure. Well, for about the past decade, I've worked with a team of researchers and community partners on a program in the United States called InShape. That is a health mentoring lifestyle fitness program that is specifically designed for people who are living with serious mental illness. It is delivered in community mental health centers, and in the United States, our community mental health centers provide they're the public health, the publicly funded services for mental health services. And so in those settings, this InShape program is delivered by a certified personal fitness trainer. So a trainer who could be working in a gym or another fitness facility. But the developer of that program, his name was Ken Ju, and he was the CEO of a community mental health center. Ken, he really believed that it was important that the fitness trainer was employed by the community mental health center so that they were integrated as part of the staff, and someone who a client person with serious mental illness would see, working in the center when they went there for therapy and other care. And so one of, I think, the real sort of important ingredients of the InShape program that a lot of people, especially clients, appreciated was that the fitness trainer who's employed by the community mental health center, it was really important for the fitness trainer to provide integrated exercise. So what that means is, in our U.S. context, that means that the fitness trainer would leave the community. They would do their work at a local gym or fitness facility or a park, if the weather was nice. But the idea is to really help the person be in an integrated setting where people with and without mental illness were exercising and working on their fitness. And so that's a real key ingredient of the InShape program. And this program's been studied in two separate randomized studies. And in both of those studies, about half of the participants enrolled had an improvement in their cardiovascular health, and that was measured by either 5% weight loss from their baseline weight or a improvement on a maximal exercise test. So the 6-minute walk test, it's how far can you walk in 6 minutes? And it's a reliable and valid measure of your improvement in your aerobic capacity. So we studied InShape in 2 randomized controlled trials, and in both it was we found it to be effective, and then implemented it and evaluated the implementation of InShape in New Hampshire at another 4 community mental health centers. And that question in that study was really more about, okay, so we have evidence that this InShape program is effective for weight loss and for fitness, but now it really becomes a question of then how can you implement this as part of routine practice without the funding, the tightly controlled sort of monitoring that comes with our randomized controlled trials. It's like, can we do this in the real world with a more hands-off approach, the research in partnership with the community mental health centers, and found out that the effectiveness was very similar to the results from the randomized controlled trial. So it's like, okay, so we can implement it in these community mental health centers in a less kind of controlled environment. Mm-hmm. And then we followed that study up with a national study of InShape, where the question was then about the way to implement it. And we implemented InShape in over 48 community mental health organizations across the U.S. Yeah.
Yeah. Wow. Okay. This is fantastic. I have so many questions. So the first one, as a former personal trainer, fitness trainer, why fitness trainers? Because it's a population that, as far as I'm aware, doesn't and hasn't in many prior trials or research worked closely with people with serious mental illness. So why fitness trainers?
Like, why would they be the interventionist, or why would why want to work?
Well, more from your perspective as a researcher, why did you choose fitness trainers?
Well, I think that we didn't choose. I mean, that's one of the, I think, really neat parts of the beautiful parts of the InShape program was that it wasn't designed by researchers. The program was designed at a local community mental health center by the CEO, Ken Ju, and his colleagues. And then we partnered with that team to then evaluate InShape. But I think from the developers' perspective was that, why not have a fitness? If I'm going to start training, I'm going to hire a fitness trainer. Why not? And why wouldn't, especially if we're talking about a group with such severe, the health disparities that we talked about at the beginning of our conversation, the people who may need it the most, one of the greatest health disparities in our country, why wouldn't we want them to be working with a trained, certified fitness trainer who can provide the proper instruction and help them along with really working on their fitness? Now, you raise a good point with, there's also, you might have been raising this point around the dietary, like the healthy eating part, and like how does a trainer fit in versus a dietitian. And that is something that our team brought to the InShape program, was a more sort of rigorous focus on training the fitness trainers around the healthy eating part, and providing people with guidance around healthy eating. But I think it was in the people who were attracted to that position, the types of fitness trainers were just very lovely people. They wanted, this was an opportunity for them to have a job working at the intersection of health and mental health, and working with people who were incredibly grateful. The clients, the participants were, very grateful to have that relationship with a trainer and someone who they felt like could support them and inspire them when they were showing up for their sessions. So I think it was really good.
Yeah, it's fantastic. Here in Australia, Kelly, we have over 30,000 fitness instructors / personal trainers, and a recent survey came out showing that they believe that, at least in Australia, the fitness instructors believe that exercise for mental health is like the number one trend that they see amongst people that they train. So there's a real awareness of the importance of exercise for mental health from our trainers. So I see like something like your program as a huge opportunity. given we also have a similar physical health disparities with people with serious mental illness here in Australia. So is InShape still running? How is it being rolled out now? Is it still nationwide and going at the moment?
So great question.
Mhm.
And we have a pending study study pending, meaning it's been reviewed by a committee and we're waiting on the final word on whether it will be funded. But we have a study that will investigate that question. So we're planning to go back out into the field and interview all 48 sites that initially implemented InShape to learn about whether the program's sustained, but not only is it sustained, so not just a yes, no, but has it been adapted? Have they made changes over time to the core protocol of the program in a way that maybe they made changes to better fit the client population. Maybe they made changes to sustain it at the setting level. So we're going to ask about adaptations. We're going to look at sustainment. And then we're also we have data from our prior trial that we can use to sort of look at some of the, what we call contextual factors. So things like funding, things like the size of the organizations. So questions like, do larger organizations, are they more able to sustain a program like InShape than the smaller organization? Is it rural versus urban? Is it the size, the number of clients that they serve? So we have data from the prior trial that we can use to look at predictors as some of the contextual factors that may help us understand what's influencing the sustainment. And then we're also going to go out and collect data on health outcomes. So in the real world, so we're going to enroll the participants who are already in these programs and collect the data on their weight and their fitness. And we just want to see how it looks now, how the program is working now that it's been sustained out in the real world. This has been 8 to 10 years now.
Wow.
It's been sustained out there, and we want to see how people are doing also in the program. Does it still? So not only is it sustained, but are there benefits for those programs that have been sustained?
Those are really important questions, right, Kelly? I mean, you'd know a hell of a lot better than I do, but sustainment of these interventions is something that is often overlooked. It's often the one and done, the helicopter research. You come in, you do your project, then you leave, and often it kind of falls to pieces when the research team goes away, right? Whereas you're looking at the long-term viability of this intervention.
Yes, that's right. And that's really the focus of implementation science, which is an area that I work in and I'm really passionate about. It's like, but even within implementation science, we still focus on sort of the day one problem of implementation. It's like, so we have the evidence that an intervention works, like say a lifestyle intervention is effective. We have the evidence. And then the day one implementation problem might be like, okay, so now can we get it implemented in the real world with routine care, with everyday, providers? But then to me, the more interesting question is like the day 500 question, is it still there? After we've put resources into sustaining it, like what happens over time? And I'm really interested in whether like a program like InShape, is it become something else? So maybe they stop calling it InShape, but it could evolve into some other intervention. And maybe that's because the organization has learned more about what really works in their setting, what's feasible, what is effective. And so maybe they're ending up with interventions that are just even much better and smarter than researchers could even conceive early on. So I think it'll be exciting we have some site visits planned too, to go out and visit these centers across the U.S. and learn about their programs and meet the trainers and so forth. And I don't want to overlook also the sites that weren't able to sustain. So there is so much to be learned from people who they had all launched InShape. They had signed up they received the training. They really wanted to make this work, and there's just a lot to be learned from, I think, those organizations as well as, about why they weren't able to sustain. And maybe they replaced InShape with some other type of health promotion. Maybe they aren't even able to provide health promotion because, at least in our context in the U.S., it's not these community mental health organizations primarily are set up to provide mental health care, mental health treatment, and mental health care. So just the fact that they integrated physical health into their array of services, and that can often be, it's not consistent with the culture and the mission of these mental health centers. So they were already doing something very innovative when they implemented InShape. And so now it'll be really fascinating to go back out and find out what's happening and learn. A part of one of the aims of the study is to, it's not just observe what's happened, but also partner with them to create some sustainability interventions. Yeah. So what could we learn to actually create an intervention around sustainability of our lifestyle interventions in mental health settings?
Yeah, so these are such important questions you're asking, but for most of us who aren't implementation scientists, who I dare say most of the audience won't have even heard of implementation science, from a research perspective, Kelly, why is the focus so much on day 1 rather than day 500? You brought up that is the way, but why is that the way?
Well, I think if you sort of step back and think about why we need something like implementation science, what's the role of it? It's like, well, because we need to address the research to practice gap. So we can do, which is the gap between, so we can do a randomized controlled trial. We can study whether there's something, clinical, behavioral, pharmacological intervention is effective. But, if that is just sitting on our shelves, and we're not moving that evidence into practice, that's a problem. We're not improving our health and the healthcare we provide. And so I think the reason why maybe this day 1 problem has gotten more attention is because that's an important enough. I mean, just to move evidence from the shelf or from your journal article into the world where people can use it and access it, that's an important thing to do. And that's really where I think implementation science sort of started. And then once we've done that, once we've learned some things about that, I think now it's becoming more there's more attention placed on, okay, we can't just focus on that sort of day 1 implementation. We have to also start thinking ahead around sustainability and sustainment in the long run. And it's also, I think that's one, I guess, sort of reason why the attention has been on the initial implementation. But if you think about it, it's not, it's real challenging to find a sort of a scenario where you can study sustainment. Right? Because you need, like in our case, we really leveraged this series of studies. It's like we had the randomized controlled trials, then we had the implementation study. So we could jump off that point and say, okay, we've done this. We've partnered with these community mental health centers. They've all received the same training. They all launched, within a 2-year period, this InShape program. So it's like now we're jumping off of that point and starting the follow-up of sustainment. I think sometimes it's just a little challenging to find a good platform to do your research on sustainment, but there are lots of creative ways to evaluate sustainment that we need to start working on.
From a research perspective, is it incentivized as much as, say, coming up with your novel intervention number 1,000 on a particular topic versus going back to an intervention 100 that's already been designed and assessing the sustainability of that already existing intervention? Are there differences in the incentivization from a researcher's career and that kind of perspective?
Well, there's a lot of energy and enthusiasm, at least in the U.S. context, but I have colleagues who work in global health, and for sure, There are people in Australia doing implementation science. There's some type of implementation science institute, I think. I have colleagues who recently went to over the summer, but in Australia. But I think there are funding mechanisms for implementation research for sure. I think it is a good question if you're asking around career stage more, like should a early career researcher take on these big questions around implementation, or is it maybe you want to work on some efficacy, effectiveness studies, intervention studies early on? I don't, probably depends on, the group you're working with, the team you're working with, and what support you have to do implementation research. But I think at least for me, really thinking about how can I contribute? Okay, so we have a number of evidence-based lifestyle interventions for people with serious mental illness. We have the InShape program I mentioned. We have Leah Cabasso, his work. I know you've interviewed him in an earlier podcast. Gail Dommett from Johns Hopkins. They've all really been leaders in developing kind of variations on these lifestyle interventions that have all been effective in their own way. And so I think the question for me really now is like, okay, how do we implement, but really the keeping things going and keeping them going at a high enough level of fidelity so that they're still effective, while also allowing or embracing these adaptations that may need to happen locally for these interventions to be sustained. I think that's just those are really exciting questions. And the thing about that research, to answer your question too, I think there's a lot of opportunity. So many questions, that need to unanswered questions, things we need to learn about sustainability and sustainment, that it's very open field, especially for a young person who's interested in that type of work.
Yeah. Okay. And this begs the question, I'll give you some background. My own PhD is on coming up with a novel intervention, but teaching psychologists here in Australia how to use exercise-based interventions for mental health in your traditional talk therapy, psychotherapy. And this is something I'm very passionate about and just want to see sustained. This is the first time it's been done here in Australia. So what are the secrets, generally speaking, to sustaining an intervention? Are there secrets that have come out from your research so far, or is it too early to say at this point in time?
Well, and my research is just going to get underway soon. But I think from the broader literature, certainly things like funding help sustainment, so being able to pay for the intervention. Things like continuity of training. So if you're training an interventionist or a provider, and you can do that in your efficacy or your early, your pilot studies, fine. You can train somebody, they can deliver a protocol, do it with fidelity. But we really also want to think about, how's that training going to be sustained? So who provides that? If this is an intervention you want to see all over Australia, be scaled up and out, and then like what kind of training needs to be sustained? What kind of supervision needs to be sustained? So we know that supervision, training, funding are important factors in sustainability, organizational. So you also want the setting in which the intervention's being delivered. Like you want that leadership to sustain support and enthusiasm for keeping that going in their clinics or in their context. So, you can think about different things. It's like the contextual factors that need to be sustained too in order to sustain an intervention.
Yeah. Okay. That sounds like a lot of work and a lot of, I can see a lot of grant applications and funding applications in my future to try and sustain any intervention. Yeah.
Well, I just want to mention, I also need to make sure to say that you can, so sustainment is that long-term problem, But sustainability is something, we want to be thinking about from the very beginning. So is this sustainable? Are there things that I'm doing that I'm preparing this intervention to be sustained in a certain setting? Is it something that my partners can see keeping going? So you can start designing for sustainability early on in your work. You can assess perceptions of sustainability. And so that's something we're also trying to do more and more of with the trainees in our programs, is to help people think about sustainability, not just sustainment. So how do you design for sustainability early on when you're developing or adapting an intervention? Can also be helpful.
Is the analogy there at day 1 already thinking about day 500?
Sure. Yeah, absolutely.
Yeah. Okay.
And thinking about it, and then it don't have to be big. You don't have to tackle, big funding issues initially, but it is good to think about, like, actually, how does this get paid for? What would it take? What would the training take? Is the training I delivered something I could create a manual for and a video for and hand off so that it's sustainable, so somebody else could deliver the training? I think just even in what may seem like small ways, those can, thinking that way and that type of design can have an impact on sustainment. So that's good. Now I've got you interested in implementation science. That was my goal.
Yeah. And I'm already, all the questions are burning now as to not just how I can make this intervention work now, but make it sustainable and sustain it in the long term, which is good. And I'm excited to see how that influences the course of my PhD. So that is exciting. Yeah. Excellent. Well, is there anything else that you wanted to add, Kelly? We've covered a lot, from physical health disparities to interventions to sustaining those interventions to implementation science broadly, but is there anything you want to add at this point in time?
Well, I think before we go, I did want to touch on, some of our work is focused on young adults with serious mental illness specifically. So, like, many of the lifestyle intervention studies have been broadly focused on people with serious mental illness. And line of our research is really try to engage younger people. And that's because we don't want to wait until people get into having these real adverse health outcomes or a very high cardiovascular risk. We want to try to engage people early on in healthy lifestyle behaviors and so forth. So we've been doing work in that area as well. And I just think it's really important for more people to be thinking about too, and in ways to deliver interventions that are normalizing. So the good news is right now, many people are interested in health and wellness and fitness. And so just because you're, a person with mental illness, it doesn't mean that you are the only one who needs lifestyle interventions. Many of us need lifestyle interventions. So I think it's a good time to really be thinking about not just because a person has a mental illness, but because, any young person, it's important to engage people in their own health and wellness. So we have a line of research on that as well.
Yeah. Okay. Fantastic. Is there a particular name for any of these interventions that you have, or research, or just a place that people can go to find out more about this if they're interested in particularly with the youth with mental illness side of things?
Yeah, so we had a trial where we worked with 150 young adults with serious mental illness, and we delivered 2 interventions. One was a group-based exercise intervention delivered by a fitness trainer. It was held at the Community Mental Health Center. The other one was almost entirely remote, so a digital healthy lifestyle intervention that included telephone coaching, text messaging support, and wearable activity trackers. And so we really tried to understand if, what's something that's a digital health promotion intervention, how does that compare to something that's in-person, group-based? And the results of that trial, it's really like there was no difference between those 2 interventions. Both had a significant change in weight from baseline to 6 months, and 6 months and 12 months. We didn't see any changes in fitness with either intervention. But we learned a lot from also talking to the young people in the study. So we learned things like, their engagement was higher in the digital lifestyle intervention. So people were able to attend more sessions than they were in person. And we did some qualitative research talking to people after the trial. And some of the things we heard were like, look, it's just more convenient. I can take a coaching call when I'm at the playground with my daughter. I can take a coaching call on the way to my job. The things that you might expect to be more related to more convenience factors. And so it was just, if you're interested in engagement, then that certainly was a way to make the intervention more accessible to people. But again, it was no difference in terms of the outcome of the group intervention, but participation and engagement was higher with the digital health intervention.
Yeah, fantastic. I'll certainly link that particular paper there in the show notes for people who want to check it out more, and some of the papers that we have covered, Kelly, because we certainly have covered a lot, which is great. And I really appreciate you coming on because, like I said, a really important conversation, not just for people working with serious mental illness who might be listening, whether it's current or early career practitioners or students about to commence in such work, but also researchers themselves. So I think a really free-ranging and valuable conversation, Kelly, which I appreciate.
Yeah, thank you for having me. This was great.
Yeah, fantastic.
Thanks so much for tuning in to today's episode of the Mental Wellbeing College. If you've made it this far, it means you've gleaned a ton of value from today's episode, or you've fallen asleep. I sincerely hope that it's the former, and if it is, I would be so grateful if you were to hit subscribe, follow, or to share this podcast with someone you care about. Our mission here at the Mental Wellbeing College is to provide a free and accessible resource for people to take action and implement to improve their own mental wellbeing. And you subscribing, following, and or sharing helps us to achieve that mission and to impact people in need. Thanks so much for tuning in. It means a lot. We'll see you next week on the Mental Wellbeing College.